Good evening, students. So today the topic that I am going to discuss is how should a resident take case history and also the art of case sheet writing. So if you have joined, you can just say hello. So this is the first video of the respiratory medicine live resident course. So already you must have seen the app. The schedule has been already uploaded. Accordingly, we will be touching all the important topics in a short duration of time. So the course duration will be 2 months, and whatever topics that I have given previously in the app, the list, everything will be done in a very comprehensive manner, students. So shall we start? Symptomatology. Okay. So first of all, whenever you come across diseases of respiratory medicine, these are the important diseases. So you have to keep in your mind, are we dealing with obstructive lung disease? Good evening, Hafsa. Restrictive lung disease? Any possibility of infective disorders? Any pleural disorders? Any pulmonary vascular disorders? Or is it an malignancy? See, for every resident, so whenever there is a patient with respiratory symptoms and you think it is belonging to respiratory system, ruling out all other causes. So these are the things that you should keep in your mind. Now this respiratory disease, can it be obstructive? You know what are the common obstructive diseases? Asthma, COPD, bronchiectasis. Is it restrictive lung disease? Especially is it ILD, fibrosis, sarcoidosis, occupational lung diseases? So we have intrinsic restrictive and extrinsic restrictive, such as kyphoscoliosis, neuromuscular disorders. Or is it any possibility of infective pneumonia, either community acquired pneumonia or infective illness such as tuberculosis? Or this patient can have any pleural disease such as fluid called as pleural effusion, air called as pneumothorax? Or can it be any pulmonary vascular disorder? Are we dealing with any pulmonary hypertension or any pulmonary embolism? Or it can be a malignancy. So if you take all the diseases in respiratory medicine, it will fit under this heading. So it has to be either obstructive, restrictive, infective, pleural, pulmonary vascular, or malignant disease. Then what are the important symptoms of a given respiratory disease? So we have cardinal symptoms such as number 1, cough. So cough is the most important symptom. Then we have shortness of breath. So the shortness of breath is also referred to as dyspnea, also referred to as breathlessness. So just giving you the list of symptoms of a respiratory disease. Then next is hemoptysis, chest pain, and any wheezing. So if there is a patient with any one of these symptoms, you can suspect possibility of respiratory disease. So these are the cardinal symptoms. You should know everything about at least these symptoms: cough, shortness of breath, and hemoptysis. Out of this, examiner will be very particular regarding cough, shortness of breath, hemoptysis. These three symptoms A to Z, it should be known by a respiratory resident. Apart from these symptoms, there are other associated symptoms that you should inquire the patient whether they are present or not. Is there any fever, night sweats? So why will somebody ask about fever or night sweats in a patient with respiratory disease? So if you are thinking in terms of tuberculosis and even few lymphomas mediastinal lesions. They can have fever, night sweats. Then white loss. It is a cardinal manifestation of tuberculosis, chronic respiratory disease, and very importantly, any underlying malignancy. So if there is weight loss, one can think of tuberculosis, a disease of respiratory system of chronic duration, any possibility of malignancy. Then hoarseness of voice. So you should also ask whether hoarseness of voice is present or absent in a given patient. So why hoarseness of voice is very, very important? It can indicate recurrent laryngeal nerve palsy. Recurrent laryngeal nerve palsy. So this recurrent laryngeal nerve palsy, it is a feature of malignancy. So whenever there is lung malignancy, it can extend and it can involve the recurrent laryngeal nerve. And another reason for hoarseness of voice is when there is extensive tuberculosis even involving the larynx. So laryngeal TB. So tomorrow you might mention in the exam there is no hoarseness of voice. Now examiner will ask you, why are you asking regarding hoarseness of voice in this given patient? So you can say, or he'll ask you, what is the significance of hoarseness of voice in respiratory medicine? So then you can mention, sir, in laryngeal TB there can be hoarseness of voice. In recurrent laryngeal nerve palsy due to an underlying malignancy there can be hoarseness of voice. Then you should ask the patient, is there any dysphagia? So again, dysphagia indicates esophageal involvement. So there can be esophageal involvement by some malignancy. So again, dysphagia, esophageal involvement by malignancy. Then headache. So how is headache relevant in respiratory disease? Can anybody answer? Why? You should also ask history of headache. So headache is a feature of hypercapnia in respiratory medicine. Headache is a feature of any brain metastasis. And also in meningitis, CNS involvement, there can be headache. So headache generally indicates possibility of hypercapnia. Hypercapnia can be responsible for headache. Then you should ask whether there is any snoring. So snoring is very, very important when you are thinking in terms of obstructive sleep apnea. Snoring is a cardinal manifestation of obstructive sleep apnea. Then how is diarrhea relevant in respiratory disease? So what are the respiratory diseases that can cause diarrhea? Especially Legionella pneumonia. So if patient is having infective signs, pneumonia, Legionella pneumonia can be responsible for diarrhea. And especially COVID pneumonia was also viral pneumonia such as COVID pneumonia was also presenting with diarrhea. Diarrhea with respiratory disease, one possibility, think of infections such as Legionella and COVID. And any rhinitis sneezing. So again, rhinitis sneezing or features of viral infection or allergic airway disease. Now there is a patient with rhinitis, sneezing, wheezing. So possibility of allergic airway disease, asthma is very, very high. And also nasal obstruction. So patients presenting with nasal obstructions and respiratory symptoms. So again, it can be due to some allergy phenomena, and even in few diseases where there are nasal polyps. So there can be respiratory diseases when there, especially in ciliary dyskinesia. So there can be development of nasal polyps and later bronchiectasis. So whenever there is a patient with bronchiectasis, BXIS means bronchiectasis, and you are thinking in terms of any ciliary dyskinesia, you should always ask about nasal obstruction. So nasal obstruction is a feature of allergic airway disease. Nasal obstruction can be a part of syndromes responsible for bronchiectasis. So in this way, nasal obstruction is very important while you are taking history. Then, is there any sore throat to the patient? So again, sore throat indicates some upper airway involvement. So sore throat, some upper airway involvement, especially viral infection. So if they mention that there is a sore throat and later fever, shortness of breath, so usually viral illness can be a possibility. Now these are the important symptoms that you should take into consideration. So if an examiner asks what are all the symptoms that you should know regarding a respiratory disease, don't just say cough, shortness of breath, hemoptysis, chest pain and wheeze. Along with that, relevant symptoms include fever. So fever is always very important when you are dealing with any infective pathology. So infective pathology such as pneumonia, fever with night sweats, high grade fever pneumonia, low grade fever generally tuberculosis, weight loss, hoarseness of voice, any dysphagia, any headache, any snoring, any diarrhea, any rhinitis, any sneezing, any nasal obstruction, any sore throat. So this is the important symptomatology. Now coming to the case sheet writing. Now coming to very important case sheet writing. So whenever this case sheet, it will be uploaded, don't worry. So important in case sheet is initially the patient's demographics. So what is the name, age, gender, occupation. So when you write a case, make sure, especially in the few examiners may not be comfortable by revealing the patient's name, but age, gender and occupation are very, very important because there are so many respiratory diseases with respect to age, gender and occupation. Then coming to the chief complaints. Now you should mention the chief complaints. How, what are the chief complaints? So this, you should say that the patient was apparently normal, or the patient symptoms started from so and so duration, and what are those important symptoms. So is it cough? Is there any shortness of breath? So generally patient will tell you his chief complaints. Is there any sputum? Is there hemoptysis? Is there any chest pain? So these are the various chief complaints a patient with respiratory disease can tell the doctor. Is there any wheeze? All those that I have discussed. And also just inquire that is there any fever. If patient is unable to say, you just give him a hint. Is there any fever, night sweats, weight loss, hoarseness, dysphagia, snoring, headache, diarrhea, rhinitis, nasal obstruction. So because sometimes patients will be not much aware of their chief complaints. So at the end you might diagnose it as some tuberculosis, but in chief complaints patient might be having fever. He might have forgotten to tell you as chief complaints, and examiner will ask you why this was not written. And when examiner asks the patient at that time will say that he had all those chief complaints. So that's why apart from what patient says, as a resident you keep in mind these symptoms also, and you retrospectively ask him whether he was having it as a main complaint. Now once you have written chief complaints, now you have to explain the chief complaints in history of presenting illness. So very important for a respiratory medicine student is, so you should be able to thoroughly explain cough, thoroughly explain shortness of breath, thoroughly explain hemoptysis. So one easy way to know this is, let it be any symptom in medicine, there is something called as ODP, onset, duration, progression. So let it be any symptom. Make sure you're mentioning onset, duration, progression. Sir, what questions should we ask regarding GERD? So GERD, most of the patients presents with chest pain. So they say that central chest pain. So I'm having chest discomfort. And GERD patients with respiratory complaints present with cough. So when there is cough, Lavanya, when there is cough and patient is showing some epigastric pain, so then you can think of GERD. So you should ask regarding the chest pain, chest discomfort. So where is it? And if the patient says that it is epigastric, so then you should ask, is it aggravated by lying down? So usually GERD related discomfort will be more aggravated on lying down, especially in supine position. Okay. Then onset, duration, progression. Then you should also ask for important symptoms. What are the aggravating factors and relieving factors? So what are the aggravating factors and relieving factors? So for any symptom, these are very important. Examiner will at least expect that you have asked the ODP, onset, duration, progression, aggravating factors, relieving factors. Then apart from that, if it is cough, you should ask whether it is episodic. So like if the cough starts, will it continuously happen? And is it episodic? So occurring once in a while. And you should also ask about diurnal, postural and seasonal variation. So when it is more, is it morning, night? Postural, sitting or lying down? Seasonal, is it coming more in the winter? Then expectoration, if at all you are asking about cough, you should also ask about the sputum. So what is the quantity, what is the color, and is there any foul smelling? So can anybody tell me the relevance of foul smell? So where do you find foul smelling sputum? So in which condition that you get foul smelling sputum? Foul smelling sputum. So foul smelling sputum is a cardinal feature of lung abscess. Lung abscess. And also postural variation. So postural variation again can be seen in lung abscess and bronchiectasis. So once again, when we discuss the symptoms, everything I'll let you know in detail. So in lung abscess and bronchiectasis, what happens is patient will be comfortable on the diseased side. When he turns to healthy side, patient will develop more cough. The reason is simple. All this time when the patient was on the diseased side, all the dirty secretions were in the diseased lung. Okay, dirty secretions were in the diseased lung. Healthy lung was not irritated. When the patient lies down onto the healthy side, all these dirty secretions can come into the airways, can go into the healthy lung, can irritate that healthy lung and can result in severe cough. So foul smell, bronchiectasis, postural variation, lung abscess, bronchiectasis and also bronchopleural fistula. So whenever there is a bronchopleural fistula also, patient will be comfortable on diseased side. But he will find it difficult while lying on the healthy side. So these are the things that you should keep in your mind when you are asking about cough. So like all other symptoms, onset, duration, progression, episodes, aggravating factors, relieving factors, is there any diurnal variation? Is there any postural variation? Is there any seasonal variation? Is there any seasonal variation? Then coming to shortness of breath, again ODP, onset, duration, progression. But for shortness of breath, progression is given by grading. So what is this grading system? I will let you know in detail. And what are the aggravating relieving factors? Again, diurnal variation, postural variation. So very important in shortness of breath is there any orthopnea? So orthopnea, patient on lying down, he is getting more breathlessness. So whenever there is orthopnea, always think of an cardiac ailment. So orthopnea, if it is significant and if there is pedal edema and raised JVP, think of cardiac cause. So don't ever forget asking for shortness of breath, and don't ever forget noting this orthopnea. Many a time, most of the patients coming to emergency department with shortness of breath, they will be referring to you as asthma, and they will be having severe orthopnea. If you put your chest, there can also be wheeze. But once see the JVP, once see his their blood pressure, so it might be due to pulmonary edema also. Then coming to hemoptysis, onset, duration, progression, like any other symptom. So how many episodes were there? Is it fresh or altered blood? So what is the amount? So very important is examiner will ask you what is meant by massive hemoptysis. So what is meant by massive hemoptysis? So their amount is very, very important. So what is this massive hemoptysis? So this also I will discuss today under the topic hemoptysis. Then is there any aggravating factors or relieving factors? So what I am doing here is for each symptom, what are the things that you should compulsory ask a patient. So this you remember for a lifetime: ODP, onset, duration, progression, aggravating, relieving factors. And depending on the symptom, you should ask regarding diurnal, postural, seasonal variation. Then coming to another cardinal symptom that we know in respiratory system is chest pain. So the next important cardinal symptom is chest pain. So in chest pain, again the same thing. What is the onset? What is the duration? What is the duration of the symptom? What is the progression? And site is very important. As somebody was asking me regarding GERD. So GERD generally epigastric. Epigastric more on lying down. And also cardiac pain. Cardiac pain is also central. So what is the character? So usually cardiac pain will be more of constricting pain, whereas your pleuritic chest pain will be more of stabbing pain. So this is very, very important. Cardiac chest pain. So cardiac chest pain, non-cardiac, especially pleuritic chest pain, pleuritic chest pain. So here let us see what will be the site, what will be the character, and will there be any radiation. So usually cardiac chest pain central, whereas this will be peripheral. So rule of thumb is cardiac chest pain, patient generally holds his fist. He cannot actually localize the pain. Whereas pleuritic chest pain, patient will point with his finger. So it is easily localized. And this is described as heaviness, constricting. This is more of stabbing chest pain. So radiation, yes. So this can radiate to neck, jaw, shoulder, arm, fingers. So whereas non-cardiac chest pain, so generally it is no radiation. It is no radiation. And one important feature of this pleuritic chest pain. If it is pleuritic chest pain, so generally pleuritic chest pain is due to inflamed pleura, rubbing of pleura. So whenever pleural membranes are approximated, pain will be very severe. So especially when patient takes deep inspiration, pain will be aggravated. So there will be increased pain by respiratory movements, especially deep inspiration. Whereas cardiac chest pain, patient generally notices that there will be increased pain by exertion. So this is important. So cardiac chest pain and non-cardiac, especially pleuritic chest pain. So whenever you say there is chest pain, examiner might ask you, so how will you differentiate cardiac chest pain and pleuritic chest pain? So you might feel that these are very basic questions. Why will an examiner ask me? I am an advanced pulmonologist. So keep this in your mind, students. Whenever there is an examiner in your exam, he will only first test your basics. So if you are very thorough with basics, he'll have very good impression on you. So if you can quickly tell the important differences between cardiac and non-cardiac chest pain, site, character, radiation and aggravation, he will have a good impression on you, thinking that so this fellow knows basics. So that is the way that you have to ask regarding chest pain. Then coming to wheeze, you should ask the patient whether he is having some cat's noise, or how will a cat make a noise, that is called as wheeze. So what is the onset, duration, progression? Again the same, onset, duration, progression. So any relieving factor and variations, is it more during the day or is there any seasonal variation? And wheezing, is the patient is having any associated skin rashes. So why skin rashes are very important? Because whenever there is wheeze and skin rash, one can think of some allergy phenomena, and what are the aggravating factors. So this will be the history of present illness of the cardinal manifestations: cough, shortness of breath, hemoptysis, chest pain, wheeze. And generally a respiratory medicine examiner will more focus on how much you know regarding cough, how much you know regarding shortness of breath, and how much you know regarding hemoptysis. And regarding chest pain, the main focus will be the difference between cardiac chest pain and non-cardiac chest pain. Now thoroughly let us see what are the basic definitions. What are the basic definitions of shortness of breath, cough, hemoptysis? So this everybody should know. So I have also taken the mechanisms for your convenience. Now can anybody tell me what is the textbook definition of shortness of breath? Don't just say that it is abnormal awareness of one's own breathing. Nothing like that. So that is a layman's term. According to American Thoracic Society, shortness of breath, breathlessness, dyspnea is defined as, this is a simple man, layman's. So this is a simple definition. Subjective awareness of breathing. But actual definition given by American Thoracic Society. So it is a subjective experience of breathing discomfort that consists of qualitatively distinct sensations that vary in intensity. So it means that patient is having some breathing discomfort, and it is consisting of so many distinct sensations that vary in intensity, qualitatively distinct sensations. So each and every person can have different sensation of breathlessness. Now you can notice that few patients will be just having a upper lobe pneumonia, but they will be more breathless. Few patients will be having bilateral viral pneumonia, they will be comfortably sitting. So it is a subjective experience that consists, so each and every patient will experience it in a different manner, that consists of so many distinct sensations that vary in intensity. So each and every patient can perceive the breathlessness in a different manner. So the same disease will not cause same amount of breathlessness in every patient. That is what is given by American Thoracic Society. So as a resident, you should know this definition. A subjective experience of breathing discomfort, because a few age-old examiners will be very particular about definitions. A subjective experience of breathing discomfort that consists of qualitatively distinct sensations of varied intensity. Now, what are the causes of breathlessness? So, what are the causes of breathlessness? Apart from respiratory disease, there are so many things that can cause breathlessness. So, examiner will ask you, what are the causes of breathlessness? Don't just say that only respiratory diseases. See here, it can be respiratory cause, cardiac cause, anxiety, respiratory muscle weakness, anemia. So once again, I see some of my residents also, even though they have been seeing the cases for many years. So the problem is anemia patient will be very breathless, and in what you call in emergency department they might admit it as some obstructive airway disease, but ultimately it would have been anemia with failure. Then also metabolic causes, DKA, especially diabetic ketoacidosis, renal failure, very commonly causes breathlessness. So I have seen patient sent to respiratory medicine in view of breathlessness. So when I have saw his sugar, it was 500. ABG was showing severe metabolic acidosis. Another patient with breathlessness coming to the referred to respiratory medicine. His serum creatinine is somewhere about 5. So these are the things that should be avoided, and don't think that breathlessness is only the manifestation of a respiratory disease. And very commonly it can be due to a cardiac disease, it can be due to anxiety, it can be due to respiratory muscle weakness, it can be due to anemia, it can be due to metabolic causes such as diabetic ketoacidosis, renal failure, and these are the causes that you should keep in mind. And this is the temporal classification of dyspnea. So many people ask me, sir, when do you call it as acute dyspnea? When do you call it as chronic dyspnea? Actually, the American Thoracic Society and also the previous edition of Harrison has categorically mentioned that chronic breathlessness is a term that should be used for breathlessness more than 1 month duration. So if a patient is having breathlessness more than 1 month duration, it is chronic. So what does it mean? Anything less than 1 month should be considered as acute. So when I say acute, what exactly is acute? So this has been given previously by American Thoracic Society and also the previous editions of Harrison. So chronic, they have mentioned it as more than 1 month. So it means that acute is generally less than 1 month duration. So again, what are the causes of sudden onset of breathlessness? So within minutes to hours. Now suppose sudden onset of breathlessness. Suppose there is a patient who says that, doctor, till morning 9 o'clock I was absolutely fine, but from 10 o'clock I am having lot of shortness of breath. So what are the diseases that can cause breathlessness within minutes to hours? So anybody can answer. What are the diseases that causes acute? In that acute, you can call it as hyperacute. So within minutes to hours. So these are the dangerous diseases. So sudden onset breathlessness and pneumonia is not a cause of within minutes to hours. It will take at least days. Pneumothorax. Patient coming to the emergency department with sudden onset breathlessness, think of pneumothorax. Any possibility of pulmonary embolism, any possibility of pulmonary edema, laryngeal edema. So there can be some anaphylaxis that can cause laryngeal edema, and acute severe asthma exacerbation. Then what are the causes of breathlessness that happens in days to weeks? Doctor, from the last 5 to 6 days, I am having breathlessness. So here you should take into consideration pneumonia, ARDS, asthma, and metabolic causes. So patient in DKA or renal failure will mention that he is having breathlessness for the last 1 to 2 days or last 1 week. Then many chronic diseases such as left ventricular failure, asthma and COPD, they can suddenly worsen and can have acute exacerbation. So if the patient is having acute dyspnea within minutes to hours, these are the conditions. Within days to weeks, it can be pneumonia, ARDS, asthma, metabolic causes. And many chronic processes have acute exacerbations. Now chronic. So if a patient mentions you that doctor, for the past 2 months I am having breathlessness. So what are all the respiratory diseases responsible for chronic breathlessness? Again, the usual culprits, pleural effusion. So pleural effusion patient will be having history generally months together, because for the fluid to accumulate and cause breathlessness, it will take that much duration. So unless if it is due to trauma and hemothorax, it might have acute presentation, but routine pleural effusion patient will have a prolonged history. COPD, it takes years to develop and progress. Interstitial lung disease is also a chronic cause of dyspnea. Then neuromuscular disorders such as this Guillain-Barré syndrome, myasthenia, all will have usually chronic duration. And again anemia. So again this patient with anemia will have history of more than 1 month. And valvular heart diseases. Again commonly misdiagnosed as some obstructive airway disease. So mitral stenosis. Is there any valvular heart diseases? Heart failure. So some dilated cardiomyopathy causing heart failure, all those. So this is the basic classification of acute and chronic breathlessness. So in acute, again you should know what are the conditions which cause breathlessness in minutes to hours. So apart from pneumothorax, always keep in your mind pulmonary embolism, any pulmonary edema, heart failure. When patient is very sick with breathlessness, think of pneumothorax, pulmonary embolism, any pulmonary edema. Laryngeal edema, asthma exacerbation is not that difficult to identify. Within days to weeks, is there any infective illness such as pneumonia, any chances of ARDS, asthma or metabolic causes? Whereas chronic, pleural effusion, COPD, ILD, neuromuscular disorders, anemia, valvular heart diseases and heart failure. Then coming to the various mechanisms by which breathlessness happens. So respiratory system pathophysiology. So this is just for you to understand. So why will breathlessness be generated? So you should think, is there any possibility of abnormal gaseous exchange? So whenever gas exchange is not happening, whenever oxygen is less, it can trigger the chemoreceptors, increasing the respiratory rate. So this pneumonia, pulmonary edema and pulmonary vascular disorders and aspiration, they can cause some ventilation perfusion mismatch, not allowing gas exchange properly. Or is it due to increased airway resistance? Now the airways are completely compressed like this. Now air cannot flow properly. So your body will try to take more respirations to facilitate airflow. Or is it due to reduced respiratory system compliance? So your chest wall may not be stretching properly. Your respiratory system is not expanding properly. So your neuromuscular disorders, respiratory muscles have become weak. Interstitial lung disease, the lung has become very hard. It is not stretching. So compliance means stretchability. Either your muscles have become weak, not allowing your lungs to properly stretch, or your lung has become very hard, as in ILD, and that will also not allow your lung to expand. Or surround your lung there are pleural collections. Because of these pleural collections, what is going to happen? Your lungs are not expanding. So when there is a patient with breathlessness and you are thinking in terms of respiratory disease, keep in your mind, is this due to some abnormal gaseous exchange? So if it is due to abnormal gaseous exchange, what is the cause? If it is due to pneumonia, give antibiotic, oxygen. If it is due to pulmonary edema, give diuretic, oxygen. If it is pulmonary vascular disorder, identify it to be any pulmonary embolism, treat it. If it is due to increased airway resistance, give drugs which will open that airways and reduce the resistance. If it is due to reduced respiratory system compliance, especially reversible causes will be pleural collection. So just aspirate the fluid or put an ICD and evacuate the air. Patient will get immediate benefit. So this is how you should think in terms of pathophysiology with respect to respiratory disease. So if the respiratory disease is causing breathlessness, is it due to abnormal gas exchange? Is it due to increased airway resistance? Or is it due to decreased respiratory system compliance? And actually, in a given disease, ultimately the mechanisms can overlap. But by coming to know what is the predominant mechanism, if you deal with it properly, patient can be treated appropriately. So that is the concept that I want you to know here. Then coming to cardiovascular pathophysiology. Why will a heart disease be responsible for breathlessness? In what way? So cardiac dyspnea in simple words is associated with increased blood and water content of the lungs, and the engorged pulmonary circulatory bed coupled with interstitial and alveolar edema stiffens the lungs. So this will not allow your lung to expand properly, and it stimulates the ventilation via J receptors. So few examiners will be very particular regarding the mechanisms. So how will a heart disease cause breathlessness? You explain. So just tell that it is due to increase, especially pulmonary edema. So they'll ask you why pulmonary edema is causing breathlessness. So there will be a lot of blood and water within the lungs. So this blood and water in the lungs will not allow the lungs to expand properly. And actually excess fluid in the interstitium. Within the interstitium there are receptors called as J receptors. Whenever there is excess fluid, that can result in stimulation of J receptors, which in turn will result in hyperventilation. Then the other causes, how will anemia be responsible for breathlessness? See, when you say there is breathlessness, how will you explain breathlessness in this given patient? They'll ask you. So if it is due to pneumonia, you can say, sir, it can be due to impaired gaseous exchange. If it is due to COPD, you can say increased airway resistance. If patient is having anemia by chance, and if that is responsible for breathlessness, it is due to inadequate oxygen delivery to respiratory muscles and other organs. So because oxygen is not properly delivered to your respiratory muscles, so they try to work hard to generate more respiratory effort. And other organs also, oxygen is not delivered, so that can also result in increased demand for oxygen, that can result in breathlessness. So anemia will cause, it is nothing but there is increased demand for oxygen. Then metabolic acidosis, thyrotoxicosis, fever, some infections, aspirin ingestion, progesterone can directly stimulate the respiratory receptors. So metabolic acidosis, thyrotoxicosis, fever, infection, aspirin and progesterone. See, aspirin and progesterone can directly stimulate the respiratory center, and that can be responsible for increased respiratory rate, which in turn increases the minute ventilation. So these are the various mechanisms by which breathlessness happen due to a disease. So respiratory disease, impaired gaseous exchange, increased airway resistance, reduced compliance. Cardiovascular system, increased blood and water in the lungs. Anemia, increased demand for oxygen. And all this acidosis can stimulate the respiratory receptors. Now when I was an assistant professor, and one time an examiner actually came from Tamil Nadu, and he was very much interested in knowing the mechanisms. Now you say there is shortness of breath. What is the neurophysiological mechanism? He is asking my postgraduate, how will breathlessness happen in a given patient? So what are the receptors responsible? So what will be the neural pathways for breathlessness? So for that, you should know the neurophysiological mechanism of breathlessness. So this I will discuss in a while. Neurophysiological mechanism. So before that, now let us see what is the grading of breathlessness. So grades of breathlessness, grades. So one, they will ask you the commonly what is MMRC grade and what is New York Heart Association grade. Just 1 minute. Yes. Animations are playing. So what is MMRC grade? So MMRC grade has been designed especially for respiratory disease, that too COPD. So the difference here is, here the grade starts from 0. Now by seeing this image, can anybody tell me what is happening here? So what is happening here? So this is shortness of breath on strenuous exercise. So this is grade 0. Then coming to grade 1. So tell me what are these images signifying? So what is grade 1? So you should know this by heart when examiner asks you. Explain MMRC grading. Grade 0 is shortness of breath on strenuous exercise. So what is this patient doing? He is walking uphill and is finding it difficult. Or when he is trying to walk very quickly on level ground, he is finding it difficult. That is grade 1. Shortness of breath on walking uphill or hurrying on level ground. Then coming to grade 2. What is this patient doing? She is walking very slowly. Because if she walks normally, she will develop shortness of breath. So this is shortness of breath on walking normally, or it can be described as walks slowly than others due to shortness of breath. Because if she walks normally, she is getting shortness of breath. Because of that, what will be the patient's complaint? She clearly mentions that, doctor, I am unable to catch up the pace of my colleagues. So grade 2 is walking slowly than others due to shortness of breath. Now what is grade 3? Patient has just walked a short distance. What is the short distance? 100 meters. 100 meters. He is finding it breathless. Then grade 4. What do you see here? Patient is just standing like that. Patient is having shortness of breath. So this is shortness of breath even while dressing, undressing, and because of that patient is unable to leave home. So this is grade 4. Shortness of breath even while dressing, undressing. It is nothing but shortness of breath at rest. But this is a very descriptive scale. The biggest advantage of MMRC is it describes very well. So that's why you will be seeing very long descriptions here. So grade 1, shortness of breath on walking uphill or hurrying on level ground. Shortness of breath on just walking 100 meters. So there will be precise description. Shortness of breath while dressing or undressing and unable to leave home. So this is a more descriptive scale called as MMRC grading. Whereas for cardiac disease, there is a simple scaling called as New York Heart Association. So you can use any of this scale, nothing to worry. So this is given as 1, 2, 3, 4. So it is shortness of breath on exertion. Shortness of breath on ordinary activity. Shortness of breath on less than ordinary activity. Shortness of breath even at rest. So this is not that descriptive, just they mention ordinary activity. Now how do you inquire what is ordinary activity for a patient? So the simple rule of thumb is you can just ask, are you finding it difficult to climb stairs? So climbing stairs is an ordinary activity. If patient says yes, it can be grade 2. Whereas less than ordinary activity is going to washroom. So you are going to the restroom and coming back. Are you finding it difficult in breathing? If the patient mentions yes, then it is grade 3. Then ask him, if you are just sitting like this also, you are having shortness of breath, then it is grade 4. Grade 2, climbing stairs. Grade 3, You can relate it to going to washroom and coming back. Whereas grade 4, patient is just sitting like this, is having shortness of breath. Now see here in shortness of breath, onset, duration, you can say. So is it acute in onset, and what is the duration? You say whether it is minutes, hours, days, weeks or months. Progression. How will you say it is progressive? If the patient mentions initially his breathlessness was grade 2, now it is grade 4. So when it started, what was the breathlessness, you should ask. Now what is the breathlessness? If patient says that initially it is belonging to grade 2, now it is grade 4, you can call it as progressive. Whereas initially grade 2, now also grade 2, it means it is stationary. So in that way, you have to assess the progression. Then there is a patient with DKA and he is having respiratory distress. So what is this special pattern of breathing? So can anybody tell me what is this special pattern of breathing? DKA and respiratory distress. So it is called as Kusumal's breathing. So Kusumal's breathing, what is meant by Kusumal's breathing? It is rapid and deep breathing. So let us see some special types of breathing. So it can be asked in your Viva. So if you consider, this is the normal respiration. So let this be the amplitude and let this be the duration. Now Kusumal's breathing means rapid and deep breathing. So very rapid and deep breathing. You can see here how many times breathing is happening, and the depth has also increased. So Kusumal's breathing is rapid and deep breathing. It is rapid and deep breathing. So patient will be rapidly and deeply taking breathing. So this is a cardinal feature of metabolic acidosis. And any DNB students here, this was asked as a last year's OSCE. So they have given a pattern like this. So there was waxing and waning with apnea. Waxing, waning with apnea. So what is this? This is Cheyne-Stokes breathing. So they have asked to describe this breathing. So there is gradual increase in the amplitude, then gradual decrease in amplitude, and there is no breath. So this is called as apnea. So this is Cheyne-Stokes breathing. This is Cheyne-Stokes breathing. So this is waxing. This is a cyclical breathing. This is a cyclical breathing. This is a cyclical breathing with waxing, gradual increase, waning, and apnea. So very important. Waxing, waning, apnea. Waxing, waning, apnea. So this will be asked as a virtual OSCE. So they'll give you a breathing pattern like this, and they will ask you, explain this breathing pattern, and where do you see this? Where do you see this? This is a classical feature of congestive heart failure. So this Cheyne-Stokes breathing is a classical feature of congestive heart failure. So why it can happen? Because in congestive heart failure, because of some unclear mechanism, your respiratory system, as the blood flow is not proper in your body, so there can be some derangement in sensing of carbon dioxide. It generally happens in CHF due to derangement in sensing carbon dioxide. So this can be asked an OSCE. They'll give you a picture like this. What is this? Explain this type of breathing, and where do you see this commonly in congestive heart failure? Then coming to Biot's breathing. So Biot's breathing is described as cluster of very deep breaths. So there will be very deep breaths apnea. Very deep breaths and apnea. Now somebody can get a doubt. Sir, how do you differentiate Biot's breathing and Cheyne-Stokes breathing? Very, very important. Cheyne-Stokes breathing is always having this classical pattern. So there will be gradual increase, decrease, apnea. So here there is no that gradual increase and decrease. So there will be cluster of deep breathings, no breath. Deep breathings, no breath. But here waxing, waning and apnea. So this is Biot's breathing, and it also happens due to some CNS disorder, especially in stroke when there is damage to pons. So when your pons is damaged by stroke or trauma, and as the disease progress, what will happen is the apnea can increase and it results in a terminal event called as ataxic breathing. So what is the terminal ataxic breathing? It is very, very irregular breathing. So there will be irregular breathing with increasing in apneic area, apneic episodes, and ultimately resulting in the respiratory arrest. So ataxic breathing can be considered as a terminal event, and after that it will be only respiratory arrest, irregular breathing and increasing episodes of apnea. So all this happens because of damage to pons, especially due to stroke trauma. So commonly they'll ask you regarding Kussmaul's breathing. They can ask you Cheyne-Stokes breathing because they're asking these two commonly. Maybe an examiner in virtual ASCII, especially DNB pattern, they can ask you what is this pattern of breathing. It is Biot's breathing. It happens due to damage to pons because of stroke trauma. And the ultimate breathing is irregular breathing with increasing episodes of apnea. So this is ataxic breathing. So this is ataxic breathing. So still we are having a lot of topics to discuss because of paucity of time. So I'll go to the next symptom, cough. So whatever I'm going to write, so I will also upload it as PDF. So you don't worry, everything will be covered. Then what is the definition of cough? So in simple words, it is forced expiration against closed glottis. And they will ask you, whenever cough is happening, tell me what are the events. And few examiners will be very particular at what velocity cough can happen. So this number is very important, 50 to 70 miles per hour. So when they cough, what is the velocity by which air is coming out? It will be 50 to 70 miles per hour. Now let us see neurophysiological mechanism of cough. How is cough happening? So this is very commonly asked. So tell me the mechanism of cough. So just examiner will ask you, tell me the mechanism of cough. So you will be actually clueless. Now cough is also an reflex happening in your body. So for any reflex to happen, there should be an input. There should be an input, and that input should get processed somewhere, and after that processor there should be an output. Now for a symptom to happen anywhere in your body, there should be an input, there should be an area of processing, and ultimately there should be an output. So for cough to happen, what is the input? What are the receptors, or what are the cough receptors in your body? So we have receptors by name, mechanical receptors, there are chemical receptors, there are thermal receptors, or receptors which are stimulated by inflammation. So where are these receptors present? So they can be present throughout your airway. So they can be present in your larynx, trachea, bronchi, pleura, pericardium. See here, the cough receptors are also a part of diaphragm. So that's why diaphragmatic irritation can also cause cough. Esophagus, and also cough receptors will be present in the middle ear. So even middle ear symptoms, that's why you should take into consideration. A patient is having a severe cough and is having middle ear symptoms, that can also be a reason. So all this efferent input is due to stimulation of these receptors. So they can be either mechanical receptors, chemical receptors, thermal receptors, or receptors which are stimulated by inflammation. Now where is this getting integrated? So it is integrated in the cough center. So what is the cough center in your body? So what is the cough center in your body? So it is referred to as nucleus of the tractus solitarius in the medulla. So this is the roughly cough center. And how is this input carried to the this medulla? By your cranial nerves? So 5, 9 and 10. So important cranial nerves here will be 5, 9 and 10. So once these efferent inputs reach your cough center, now your cough center will give a reaction. That reaction is cough, nothing but an efferent output. And this efferent output will be through your phrenic nerve, intercostal nerve and vagus nerve. So from the medulla, these will be stimulated and ultimately it results in cough. So what is happening in cough? The respiratory muscles will tightly contract because phrenic nerve is getting stimulated. The respiratory muscles will get contracted. So once the respiratory muscles are getting contracted, there will be positive intrathoracic pressure. So once this area is getting compressed or contracted, there will be more pressure within the thoracic cavity. And once there is huge pressure, there can be sudden opening of glottis. So once there is sudden opening of glottis, all this air which has been preserved at that high pressure will rapidly expel out. So this is the precise mechanism of cough. So the mechanical receptors, the chemical receptors, thermal receptors or inflammatory receptors can get stimulated. And through this nerves 5, 9, 10, it can go into the cough center. From the cough center, phrenic nerve, vagus nerve, intercostal nerves will come and stimulate your respiratory muscles. So the diaphragm can be stimulated, the intercostal muscles can be stimulated. Once the muscles contract, there will be excess pressure in the thoracic cavity. And once that pressure increases, there can be sudden opening of glottis. So to decompress that pressure, so due to that sudden opening of glottis, air will come out at a very rapid flow. So this rapid expiratory flow is nothing but cough. So this is the mechanism. Now once again, you should ask what is the onset and duration. So for cough, there is precise onset. You can divide it into acute, subacute and chronic. So acute cough is usually less than 3 weeks. So what are the conditions responsible for acute cough? So viral infection, bacterial infection, aspiration or inhalational injury. Pulmonary embolism can also cause cough and also hemoptysis. Pulmonary edema and early manifestation of asthma, GERD and early upper airway cough syndrome. So this upper airway cough syndrome is nothing but post-nasal drip. So if you can identify it very early, so these can also be seen. So usually asthma, GERD, USCS, upper airway cough syndrome come to us as chronic cough. But if you are having very good clinical acumen and if you have taken very good history, you can identify it early also. Whereas subacute cough, so this is what we routinely see in our OPDs. So patient says that doctor, I am having cough for the past 1 month, 3 to 8 weeks. So usually it can be atypical pneumonia and post-viral cough syndrome. So once there is an upper respiratory tract infection, so this upper respiratory tract infection can later result in some post-viral cough syndrome. Whereas chronic cough, if patient is having more than 2 months or 8 weeks, so think of routine asthma, GERD, upper airway cough syndrome, and there is also a special entity called as non-asthmatic eosinophilic bronchitis. Non-asthmatic cough syndrome. So I think it is audible only. So asthma, GERD, upper airway cough syndrome, non-asthmatic eosinophilic bronchitis, pulmonary tuberculosis, COPD, ILD, neoplasia. So this is how you should differentiate the cough duration. So when do you call it as a acute cough? Less than 3 weeks duration. When do you call it as subacute cough? 3 to 8 weeks duration. When do you call it as chronic cough? More than 8 weeks. So examiners will be especially particular regarding this chronic cough. So they'll ask you, tell me what are the causes of chronic cough. So at that time, you should not get a thought block. So what causes chronic cough? So at least know that asthma, GERD, upper airway cough syndrome, pulmonary tuberculosis. Don't miss pulmonary tuberculosis as long as you are in India. Then COPD, interstitial lung disease and neoplasia. So this is where most of the students, when examiner asks what are the cause of chronic cough, you know all these diseases, but you will get a thought block. So don't forget that tuberculosis, COPD, ILD, neoplasia, asthma, GERD and upper airway cough syndrome are the causes of chronic cough. So here important is chronic cough. Then examiner will ask you, what are the causes of dry cough? So we know about productive cough. So typical pneumonia will cause productive cough. Bronchiectasis will cause productive cough. Lung abscess will cause productive cough. Then what are the causes of dry cough? Generally pleural effusions is a common cause of dry cough. Then you have atypical pneumonia. So atypical pneumonia is a common cause of dry cough. So interstitial lung diseases is a cause of dry cough. ACE inhibitors and GERD. So GERD dry cough, ILD dry cough, ACE inhibitors and atypical pneumonias, especially viral pneumonias. So we have seen in COVID era, most of the coughs were dry coughs, and atypical bacterial pneumonias that we have are mycoplasma, and also Legionella. Then pleural disorders such as pleural effusion. So very simple. If examiner asks you what are the cause of dry cough, you should keep this in your mind. Then what are the causes of productive cough? So productive cough, especially bacterial pneumonias, lung abscess, bronchiectasis. So under productive cough, you should be able to tell it is bacterial pneumonia, lung abscess, bronchiectasis. Whereas dry cough, the atypical pneumonias, usually viral pneumonias, the pleural disorders, interstitial lung diseases, ACE inhibitors generally cause dry cough. ACE inhibitors such as enalapril, captopril, GERD. So this is regarding causes of dry cough and productive cough. Then coming to special types of cough. So they might ask you where do you get a barking cough? So barking cough is generally a feature of laryngeal involvement. It can happen in laryngotracheobronchitis. Then when do you get a bovine or silent cough? So this bovine or silent cough happens in recurrent laryngeal nerve palsy. So especially in few malignancies, the recurrent laryngeal nerve can get affected. So there you can get bovine cough. So what else can happen in recurrent laryngeal nerve palsy? There can be hoarseness of voice. There can be hoarseness of voice. Then whooping cough. So whooping cough means patient will have continuous episodes of cough. He will be coughing like this and he will take a inspiratory gasp at the end of last cough. So this is characteristic of pertussis. This is characteristic of pertussis. Then brassy or metallic cough. So this actually we see in a Indian scenario. So when there is a big lymph node and it is compressing onto the bronchus. So because of compression of large airway, there can be a brassy or metallic cough. So all this will be available as a recorded video once this session is completed. So as a postgraduate, you should at least know special types of this cough. So what is barking cough? So what is bovine or silent cough? So what is whooping cough? And what is brassy or metallic cough? So barking cough, bovine or silent cough, whooping cough, then brassy or metallic cough. It is characteristic of lymph node compression or trachea. So then once you are asking about cough, you should also ask about sputum. So we have seen what are the cause of dry cough, what are the cause of productive cough. Then color of sputum is very important because few respiratory diseases have peculiar sputums. Now you only answer me, this is a red rusty sputum. So here examiner will ask you, what are the conditions associated with red rusty sputum? So it will be red but not red as blood. It will be red as iron rust. So can anybody tell me what is the infection responsible for red rusty sputum? Yes, common infection. Common cause of pneumonia. What causes red rusty sputum? It is streptococcal pneumonia. It is streptococcal pneumonia. Then what causes red? Very good, Karthik. It is streptococcus. So this is jelly-like sputum. What causes red jelly sputum? What causes red jelly sputum? So what is the organism? Red currant jelly sputum. It is, yes, Klebsiella. So it is Klebsiella. So what generally causes a yellowish brown sputum? So yellow to brownish sputum. So it can be seen in usual bacterial pneumonias, especially staph pneumonias. Staph pneumonias. Yes, Pragati, Klebsiella will cause red currant jelly sputum. Then, what causes a greenish sputum? So what are the infections that cause greenish sputum? So greenish sputum is characteristic of Pseudomonas. Then what causes pink frothy sputum? What causes pink frothy sputum? So can anybody tell me what causes pink frothy sputum? It is pulmonary edema. It is pulmonary edema. Then what can cause blackish sputum? What can cause blackish sputum? It is usually fungal infections. So whenever examiner is peculiar about color of the sputum, so he might ask you, tell me the causes of red rusty sputum, red currant jelly sputum, what causes brownish sputum, what causes greenish sputum, what causes pink frothy sputum, what causes blackish sputum. So this is in total regarding cough. So we have seen what is cough, how is cough happening, so what is acute cough, what is subacute cough, what is chronic cough. What are the causes of dry cough? What are the causes of productive cough? So what is barking cough? What is metallic cough? What is bovine cough? And what are the various colors of sputum? So when examiner is particular about a symptom called as cough, each and every examiner will be having one symptom as their strength. Some might ask you regarding shortness of breath. Some might focus more on cough. Some might focus more on hemoptysis. So now next, let us see what is this sputum. What is this symptom? Blood in sputum. So hemoptysis means blood in sputum or expectoration of blood, coughing out blood. In simple words, expectoration of blood or coughing out blood. So I think most of you must be knowing that your lung is having dual blood supply. So accepted. So what are the two blood vessels that will supply to your lung? One is high pressure systemic circulation. So one is high pressure systemic circulation, that is your bronchial artery. So bronchial artery. So other is low pressure pulmonary circulation. Other is pulmonary artery. This everybody must be knowing. Lung is having two sources of blood supply. One is your high pressure systemic circulation, that is bronchial artery, which is a branch of your systemic circulation. Other is your pulmonary artery. Within the pulmonary artery, generally the pressure will be low. And point to know here is, whenever the patient is coming with hemoptysis, so what will be the source of blood? Where, from which artery blood is usually coming from? Now there is a high pressure circulation and low pressure circulation. Which has more tendency to rupture? High pressure. Because it is rupturing at high pressure, blood loss might be more and it might be difficult for your body to control, and it can result in massive hemoptysis. So in very simple words, most common source of hemoptysis and massive hemoptysis is bronchial artery. So if there is a patient with hemoptysis, so in 95%, why hemoptysis is happening? It is not due to pulmonary artery. It is due to bronchial artery. So that's why as an ultimate treatment for hemoptysis, we are doing bronchial artery embolization, not pulmonary artery embolization actually. So bronchial artery is most common source. Then what is meant by massive hemoptysis? When do you call it as massive hemoptysis? Again, there is a controversy in this definition. The few books says it is 100 ml and few books says it is 150 ml. Always safe to mention more than 100 to 150 ml of blood per episode. If the patient is expectorating more than 100 to 150 ml of blood per episode, or more than 400 to 600 ml of blood per day. So if throughout the day, if patient is coughing out half liter of blood, or in a single episode it is 100 to 150 ml, then you can call it as massive hemoptysis. So then you can call it as massive hemoptysis. So what is cause of most common cause of hemoptysis in India? So say it loud and proud. This is our national disease, that is tuberculosis. Just like national animal, national bird, we have a national disease called tuberculosis. Now in worldwide also it is tuberculosis only. Don't get confused, because nowadays we Indians are worldwide. It is our responsibility to share. We share everything, nuisance on WhatsApp and Facebook. In the same way we are sharing our national disease called as tuberculosis. But whenever a patient comes to you with massive hemoptysis, So it can be bronchiectasis. Recent studies have shown that most common cause of massive hemoptysis is ultimately bronchiectasis. Now the examiner might ask you, there is a patient with hemoptysis and you are thinking it to be tuberculosis. So what are reasons for hemoptysis in tuberculosis? So in tuberculosis, why will there be hemoptysis? So in tuberculosis, so why there is hemoptysis? How can TB cause hemoptysis? So number one, so cavity. So there can be a cavity. So that cavity can erode a blood vessel. Cavity can erode blood vessel. So this is most common. And TB itself can cause bronchiectasis. So that can be responsible for hemoptysis. So within the TB cavity, there can be aspergilloma. So that can be responsible for hemoptysis. So at least when there is a TB patient and he is having hemoptysis, examiner will expect you to know. So why hemoptysis is happening in this TB patient, you should at least say it can be due to cavity, it can be due to bronchiectasis, it can be due to aspergilloma. So there are also other causes. It can be due to endobronchial TB, it can be due to a broncholith, it can be due to a fibrotic scar. So fibrotic scar can also rupture and it can cause hemoptysis, but common cavity, bronchiectasis, aspergilloma. Then what is the most common cause of death in massive hemoptysis? Now this, as a postgraduate, you should answer me. So why will a patient die in massive hemoptysis? Anybody? Why will a patient die in massive hemoptysis? So will he die commonly due to hypotension shock? No. So in massive hemoptysis, it is not due to hypotension and shock. So whenever there is excess blood in your lungs, so blood can also reach your trachea ultimately. So blood out of blood vessel has always tendency to clot. So if at all there is hypotension shock, for blood loss to happen, BP to fall down and to develop shock, it will take 10 to 15 minutes. But if somebody tightly holds your neck, how much time you can survive? Not more than 2 to 3 minutes. Always cause of death in massive hemoptysis is asphyxiation with blood clot. It is asphyxiation. Yes, very good. Aspiration and ultimately asphyxiation with blood clot. Then if at all there is a patient with massive hemoptysis, what is most important in management? So is it airway or circulation? It is usually airway maintenance. So this also you should be able to answer. So airway maintenance. Death in hemoptysis is generally asphyxiation with blood clot. And most important in management of massive hemoptysis, apart from circulation, it is airway maintenance. So here key points that you should know in your Viva is, make sure you know that hemoptysis is commonly due to bronchial artery. So what is the definition of massive hemoptysis? Most common cause of hemoptysis, and why will a patient die in massive hemoptysis? Another common question in your clinical case discussion, whenever there is a patient with hemoptysis, examiners ask you is, what are non-pulmonary causes of hemoptysis? So he'll just ask you, what are the non-pulmonary or what are the non-respiratory causes of hemoptysis? So for that you should know the etiology of hemoptysis. So etiology of hemoptysis, mostly infective, neoplastic, cardiovascular, systemic causes and traumatic causes. So trauma, you everybody know. So damage to lung or damage to some blood vessel. Now infective causes, it can be any infection. So it can be any infection. So most common is infection due to the big boss tuberculosis. So other bacterial infections, viral infections, fungal infections, and infection of central airways, simple bronchitis, or more complicated phenomena associated with destruction, bronchiectasis. And malignancies, usually primary tumors of lung, then metastasis. Now this is where examiners will be more focused on non-pulmonary causes of hemoptysis. So you should at least tell, sir, mitral stenosis is a cause of hemoptysis. Cardiac failure is a cause of hemoptysis. Apart from that, this pulmonary embolism is not a lung disease, it is a vascular disease. Pulmonary AV malformations. Pulmonary arteriovenous malformations. So these are all various non-respiratory causes: mitral stenosis, cardiac failure, pulmonary embolism, pulmonary AV malformations. Apart from that, systemic diseases. Again, these are not direct lung diseases, such as coagulopathy, Goodpasture syndrome. So why in Goodpasture syndrome there can be hemoptysis? Because there are autoantibodies against glomerular basement membrane, which causes hematuria, against alveolar membrane, which will result in hemoptysis. Apart from that, hemoptysis can be a feature of CTD associated lung disease. So what is CTD? It is connective tissue disorder. These connective tissue disorders, such as rheumatoid arthritis, scleroderma, SLE. CTD means connective tissue disorder. They can directly involve your lung. They can directly damage the vasculature also. They can result in hemoptysis. And small vessel vasculitis. So don't ever forget small vessel vasculitis as a cause of hemoptysis in your history. So what are small vessel vasculitis? Wegener's granulomatosis, microscopic polyangiitis, and Church-Strauss syndrome. In this, the pulmonary microvasculature can be damaged, and that can be responsible for hemoptysis. So when you are having hemoptysis as a symptom, make sure you are knowing the source of hemoptysis and etiology of hemoptysis. So it can be classified in a very simple manner. See, theory writing is different, but in practical exam, even though it is concise, you have to express whatever you know. So just keep in your mind, etiology can be classified into infective causes, neoplastic causes, cardiovascular causes, systemic causes, traumatic causes. And examiners will be very particular regarding non-respiratory causes of hemoptysis. So non-respiratory causes, we have this: mitral stenosis, cardiac failure, pulmonary embolism, pulmonary arteriovenous malformation. So with this, we have seen three important symptoms: shortness of breath, cough, hemoptysis, whatever theory is required. Now general examination and in respiratory diseases. So significance of general examination. So they will ask you in general examination, you have to see anemia, in the sense you have to write it as pallor, icterus, is there any clubbing, is there any lymphadenopathy, is there any pedal edema. Now my question to you is, suppose you say that, sir, there is pallor in this given patient. Now examiner, if he is very smart, he will ask you, so what is relationship? So what is relationship of pallor in respiratory disease? Can anybody tell me? So pallor generally indicates anemia. So what all can be causing, cause anemia in a patient with respiratory disease? So especially tuberculosis. So tuberculosis can also involve bone marrow and it can cause anemia. Lung cancer, because of some paraneoplastic syndromes, it can cause pallor. And alveolar hemorrhage, it can cause pallor. See, what is the cause of, what is recurrent hemoptysis? So actually, for persistent hemoptysis, for recurrent hemoptysis, there is no standard definition in any textbook. It is all based on clinical judgment. So any hemoptysis which is persisting for more than 2 weeks is persistent hemoptysis, or any hemoptysis so which is happening continuously, or which is happening in a span of 2 weeks, it can be called as recurrent hemoptysis. So actually there is no standard definition, but based on clinical judgment, if somebody is having hemoptysis even after giving treatment for more than 2 weeks, so that is considered as persistent hemoptysis. In some books it is also written as recurrent hemoptysis. But according to textbooks, this recurrent hemoptysis, persistent hemoptysis are very vague terms. Now coming to general examination, if there is pallor, if examiner asks you how do you relate pallor to respiratory disease? So pallor can happen, anemia can happen in tuberculosis, in lung cancer and alveolar hemorrhage. Then next, what is this? What is this sign? What is this yellowish discoloration called as? What is this yellowish discoloration called as? You should not call it as jaundice. It is better to call it as icterus. Icterus. So this icterus. So why will icterus happen in respiratory disease? If there is a patient with respiratory disease and you are having icterus, so examiner will expect you to answer why there is, how is respiratory disease related to icterus? It can be due to ATT. ATT induced hepatitis. So this anti-tubercular drug can be responsible for some hepatitis and it can be responsible for icterus. Then lung metastasis into liver can cause icterus. Miliary TB, where there is liver involvement. See, TB can cause everything. TB can cause pallor. TB can cause icterus. TB can cause icterus. Then, what is this? What is this bluish discoloration of tongue called as? What is this bluish discoloration of tongue called as? So this is cyanosis. So how is cyanosis related to respiratory failure? Anything, any severe respiratory disease, severe hypoxemia. So cyanosis is actually a sign of severe hypoxemia. Severe hypoxemia. So if there is cyanosis, it indicates that there is hypoxemia. Then what is this? Yes, what is this common sign? So this is clubbing. So how is clubbing related to respiratory disease? So what are the mechanisms? And what do you infer from clubbing? What are the theories? What are the grades? They will ask you. This clubbing is very, very important and it is an examiner's favorite question. So clubbing I will discuss in detail. Don't worry. Then what is this? So this is any lymph node enlargement. So how will lymph node enlargement be related to respiratory disease? So if there is a lymph node and patient has come to you with respiratory symptoms, so what can be the possibilities? So always when there is a lymph node, think of any possibility of cancer. And when you are thinking in terms of in malignancy, always examine the lymph nodes in the neck. So lymph nodes in the axilla, you should examine. So lymph node enlargement can be a possibility of malignancy and very common in India, TB. Now if you see here, TB is the universal answer. So pallor, bone marrow tuberculosis. Icterus, miliary TB, ATT-induced hepatitis, anti-tubercular therapy. Cyanosis, severe hypoxemia. So patient is having bilateral fibrosis as in tuberculosis, severe hypoxemia. Clubbing, TB is a rare cause of clubbing. And lymph node enlargement, again it is TB malignancy. So when you see the general examination, so in some they call it as pickle signs or something like that. So this is pallor, icterus, cyanosis, clubbing, lymph node enlargement, and what is left? What is this? Is there any edema, especially pedal edema? So how is a respiratory disease responsible for pedal edema? So when you see a patient with respiratory disease and you are seeing pedal edema, what you should suspect? So first of all, if it is due to pure respiratory disease, why will pedal edema happen? One important thing is, has the patient gone into cor pulmonale, or patient is having shortness of breath, raised JVP, pedal edema, it can also be due to heart failure. But pure respiratory disease responsible for pedal edema, it can be cor pulmonale. And if it is unilateral pedal edema, painful pedal edema, and patient is having severe shortness of breath, think in terms of pulmonary embolism, it can be DVT. So what is importance of pedal edema in general examination? If there is pitting pedal edema, painless pedal edema, think of cor pulmonale. If there is unilateral pedal edema and it is painful, think of DVT. So in this slide, what we have understood is relationship between general examination finding with respect to respiratory disease. How is pallor related? How is icterus related? How is cyanosis related? How is clubbing related? How is lymph node enlargement related? And how is pedal edema related? So at least you should know these points. Then theories of clubbing. So let us see clubbing in general. So there is neurogenic theory, hypoxic theory, humoral theory. So examiner will be straightforward. Now once you have told there is clubbing, what are the theories of clubbing you know? So just know the names, neurogenic, hypoxic, humoral. And out of this, most famous theory right now is humoral theory. So humoral means it is made up of some mediators. So can anybody tell me what are the important mediators causing clubbing? So what are the important mediators causing clubbing? So all this will be asked in your practical exam. So if you say clubbing is present, first thing they'll ask you definition. They can ask you grades. They can ask you to demonstrate that Shamraj sign. They can ask you that profile sign, and they can ask you what are the theories of clubbing. So first of all, let us see what is the humoral theory. See, generally megakaryocytes. So megakaryocytes are nothing but mother platelets. So from the megakaryocytes we get platelets. So these megakaryocytes usually undergo fragmentation within the pulmonary capillaries. So from the bone marrow they are transported into the pulmonary capillaries. There these megakaryocytes will be broken down and they come into circulation as platelets. But whenever there is a right to left shunt or damaged pulmonary capillaries as in inflammatory and neoplastic disorders or some abnormal pulmonary arteriovenous malformations. Now usually what should happen in the pulmonary circulation, these megakaryocytes should be broken down. But if there is a right to left shunt, so the blood is coming from the bone marrow into the right heart. It is not going into pulmonary circulation, directly into left heart. Or the pulmonary capillaries have been damaged. So they are unable to filter these megakaryocytes because of some inflammatory or neoplastic or some abnormal connections between pulmonary arteries and veins. So because of this, all these megakaryocytes will go into the systemic circulation. So because of these entities, megakaryocytes bypass the lung capillary network. So if they come into capillary network, they will be broken down and they come out as platelets. That is normal. Because of these events, they bypass the lung capillary network and enter the systemic circulation. So because of that, all these big platelets they come and get impacted in the peripheral circulation, especially in the fingertip circulation. So fingertips and also toe tips. And these megakaryocytes, because they are big platelets, they produce these substances: platelet derived growth factor, vascular epidermal growth factors. So all these are growth factors: platelet derived and vascular epidermal derived growth factors. Now what will this growth factor do? It will be responsible for proliferation of more soft tissue within the terminal phalanxes. Because of this soft tissue proliferation, there will be bulbous enlargement. So that will result in increased blood flow and connective tissue changes of clubbing. So because of these growth factors, there will be increased blood flow and also lot of connective tissue deposition that results in clubbing. So because of this, there will be bulbous enlargement of terminal phalanges of fingers and toes. Bulbous enlargement of terminal phalanges of fingers and toes. So this is called as clubbing. So in simple words, normally megakaryocytes should be broken in the lung. So when there is some issue like this, right to left shunt or damaged pulmonary capillaries as in inflammatory neoplastic disorders or some AV malformations, these bypass and reach into the systemic circulation. Now these big platelets, they will not keep quiet. They will produce these substances called as growth factors that will result in increased blood flow and proliferation of subungual connective tissue that will result in bulbous enlargement of terminal phalanges of fingers and toes. So this is in short called as humoral theory. So in humoral theory, so what are the names that you should at least know? Platelet derived growth factor and vascular epidermal growth factor. So this is the most simplified version of humoral theory. If you go through any book, ultimate bottom line is megakaryocytes reaching the peripheral circulation, producing growth factors, resulting in excess growth of soft tissue within the terminal phalanges of fingers and toes that results in clubbing. Now coming to what is the normal Lovibond angle. So you should know that the angle is 160 degrees. So Lovibond angle is the angle between the nail base. So you can see here. So you can see this is the angle. Okay. So this is Lovibond angle. It is usually, so this is the nail base angle. So it is usually 160 degrees. So in clubbing, there will be obliteration of this angle. So it can become more than 180 degrees. So this is again a very important question. So the nail base angle is usually 160. So this is referred to as Lovibond angle. This is referred to as Lovibond angle. So in clubbing, what is going to happen to the angle? It will be more than 180 degrees. And another commonly demonstrated sign is this Shamroth sign. So they will ask you demonstrate clubbing. So one thing you can see from the sidewards. So this is called as profile sign. So if you see the profile sign, if you can identify the angle as 160 degrees, so or you can see there is no bulbous enlargement. So you can see there is no bulbous enlargement. So it is negative for clubbing. Or they will ask you to keep your finger, they'll ask you how do you demonstrate Shamroth sign. You should approximate the both nails together. So if there is no clubbing, you can see a diamond shaped structure. So whereas the diamond shaped structure is obliterated. So this is a Shamroth sign. So in Shamroth sign, you can see normally a diamond shaped structure. So in clubbing, the diamond shaped structure is not seen. So either you can see by this Lovibond angle. So Lovibond angle means seeing the side on view. This is also called as profile sign, or approximating the Niles and looking for that diamond shaped structure. So if it is not present, it means there is clubbing. So these are the two common ways of assessing clubbing. One is by seeing from sidewards, Lovibond angle, and other is observing the Shamroth sign. Then what is the most severe form of clubbing? Or by seeing these images, you tell me what is this entity. So there is in this image there is clubbing, and if you notice keenly, can anybody identify? This can be asked as a virtual OSCE. So they'll ask you, they'll give you these three images. So they'll give you this finger, this joint image, and also this X-ray. So what you can see on this X-ray, so can you see this whitish periosteal proliferation? So this is a combination of clubbing, this is arthritis, and there is periosteal proliferation. This is most severe form of clubbing. What is most severe form of clubbing called as hypertrophic osteoarthropathy. So what will this released growth factors do? As time progress, it will not only involve the tips, it will also involve the fingers, it will also involve the joints. So this most severe form of clubbing is called as hypertrophic osteoarthropathy. So these released growth factors will increase the vascularity and it will stimulate fibroblasts and osteoblasts. That results in not only finger clubbing, periosteitis. Can you see around the bones there is proliferation, and also there will be arthritis. And this is also referred to as painful clubbing. So this is also referred to as painful clubbing. Generally clubbing is painless. But when there is a painful clubbing with joint involvement, it is called hypertrophic osteoarthropathy. And in which condition you see this? It is seen in adenocarcinoma. Adenocarcinoma is a common cause of hypertrophic osteoarthropathy. Adenocarcinoma is a common cause of hypertrophic osteoarthropathy. So what are the features of hypertrophic osteoarthropathy? Finger clubbing, periosteitis, and arthritis. Finger clubbing, periosteitis, and arthritis. So we have seen the important clinical symptoms, and also I have discussed the general examination findings. Where do you see pallor, icterus, clubbing, lymphadenopathy, pedal edema, and in general clubbing. Now let us see this case sheet writing. So this will be again uploaded for you. Now whenever the patient complains of fever, like any other fever, you should write whether it is high grade or low grade. So if a patient is able to tell what was his maximum temperature, you can note it down. So what is the type of fever? Is it continuous fever or is it intermittent fever? Is it associated with chills and rigors? Is there any diurnal variation? Peculiarly, evening rise of temperature is a characteristic feature of tuberculosis. Is it associated with night sweats? How is it relieved? Now, is this patient having fever? Has it decreased? Then you should also ask in respiratory disease, this history of loss of appetite and loss of weight. So this loss of appetite and loss of weight, this is loss of appetite or any weight. So if you are able to document, you can document from how many days and what is the progress and how much amount of weight he might have lost. And as I told you, apart from this cardinal symptoms, shortness of breath, hemoptysis, chest pain, wheeze, whenever there is a respiratory disease, you should ask any history of hoarseness of voice, dysphagia, any rhinitis, any snoring, any excess daytime sleepiness. Again, excess daytime sleepiness is a feature of obstructive sleep apnea. Why excess daytime sleepiness? For obstructive sleep apnea. Is there any headache? Is there any palpitations? Is there any syncopal attacks? Any pedal edema, facial puffiness, abdominal distension? See, not only including respiratory symptoms, if patient is just presenting with shortness of breath and wheeze, examiner will ask you, why can't it be cardiac? So you should also rule out other features of cardiac disease. So is there any orthopnea? Is there any pedal edema? Is there any palpitation? Is there any syncopal attack? So you should also take some negative history. So like this, you have to complete the history of present illness. You have to explain cardinal symptoms in detail. Explain cough, shortness of breath, hemoptysis, chest pain, wheeze in detail, and fever in detail you should explain. Whereas other symptoms, you can just mention whether it is present or absent. Now once the history of presenting illness is done, next you should know the history of past illness. So what all past illness is very relevant. So has the patient had any similar complaints in the past? So if the patient had any similar complaints such as shortness of breath or cough in the past, and history of diabetes is very important, hypertension is very important. So diabetes closely related with so many lung infections, fungal infections, tuberculosis, any hypertension. So OSA hypertension again is a deadly combination. Any asthma, any TB, any leprosy, epilepsy. So why epilepsy is very important? Because epileptic patients can develop aspiration or any cardiovascular abnormalities. Patient had any congenital heart disease and any recurrent childhood chest infections. Why one should ask about recurrent childhood chest infections in past illness? Because bronchiectasis. Now there is a patient with bronchiectasis. This childhood chest infection might be responsible for bronchiectasis. So in history of past illness, any history of similar complaints in the past, history of diabetes, hypertension, asthma, TB, leprosy, communicable diseases, epilepsy, for aspiration possibility, cardiovascular abnormalities, any history of recurrent childhood chest infections. Then very important is you should ask about history of tuberculosis. So once you are asking about TB history, make sure you are asking about ATT also. So how many, if at all patient says that he is having tuberculosis, if he is having tuberculosis, so first thing, was it pulmonary or extrapulmonary? You should ask him if patient is able to say. How was the diagnosis made? How was the diagnosis made? Was it based on chest X-ray finding? Was it based on sputum? So was it sputum positive tuberculosis or negative based on chest X-ray? So what was the follow-up sputum? What was the regimen given? What is the duration of treatment? Did he take the drugs properly? So how many times he has taken the drugs? Was it government or private? And important dates if possible. So when was he diagnosed? So which year? And when did he complete? So in which year he has completed? And what was the ultimate result? Was it treatment completed, cured, or lost to follow-up or defaulted? If at all you say patient has not taken the treatment properly, that is not the right way to answer. So why did he not take? Was there any tolerance issue? Was there any program issue? And if possible, you have to document all his CBNAT, LPA, liquid culture reports. So especially when you say past history of TB is present, don't run away by saying past history of TB is present. So how was it diagnosed? Was it pulmonary TB or extrapulmonary TB? Sputum positive or negative? What was the chest X-ray finding if available? So what was the end result? Did he complete the treatment or not? And what was the regimen that he has taken? Was it drug sensitive TB or drug resistant TB? Now drug resistant TB is very common. So what was the duration of treatment and all this, and any history of significant surgeries underwent in the past. Then coming to treatment history, what all drugs that can cause respiratory events. So is there any ACE inhibitors? ACE inhibitor is a common cause of cough. Amiodarone can cause lung fibrosis. So all this chemotherapy, radiotherapy can result in fibrosis, ILD later on. Has this patient been on ART? Now there is a patient with features of pneumonia. He is taking ART but not properly. Now your diagnosis completely changes. So it will be pneumonia in immunocompromised. Instead of thinking of common organisms, you can think of pneumocystis pneumonia and other uncommon organisms. And in the family, next after treatment history, has he taken any ATT, ART, ACE inhibitors, amiodarone, chemotherapy, radiotherapy, etc.? Any history of asthma, TB, diabetes, COPD, malignancy, ILD. ILD can run in family. Malignancy can run in family. COPD can run in family. So which COPD runs in family? Alpha-1 antitrypsin deficiency. Alpha-1 antitrypsin deficiency. Then coming to personal history. So in the personal history, what was his diet? Any history of sleep disturbance, and what are his bowel and bladder movements, smoking and alcohol habits. So, and especially you have to calculate if he is a smoker, number of pack years. So number of pack years, this is the standard formula. Number of years into number of cigarettes by day divided by 20. So for BD there is no standard calculation. So few books mention it to divide by 10, but there is no proper BD index. Then smoking index is equal to number of years into number of cigarettes per day. This is very important. So smoking index is number of years into number of cigarettes per day. That's all. Whereas pack years is number of years into number of cigarettes divided by 20. So for pack years, it is to be divided by 20. Smoking index, it is not divided. It is just the result of number of years into number of cigarettes. Whereas this is division. You have to divide number of years into number of cigarettes per day divided by 20. This is very important. Don't get confused by pack years and smoking index. Smoking index is just number of years into number of cigarettes per day, whereas pack years is number of years into number of cigarettes per day divided by 20. In simple words, pack years is nothing but smoking index divided by 20. So after that, any contact history. So any contact with tuberculosis, HIV or smoking. So passive smoking can also result in so many diseases. So general examination, weight and height you have to take, and accordingly you have to calculate BMI. So only by BMI you have to say whether the patient is adequately nourished or malnourished, and what is his consciousness level, what is his orientation. So any general examination, any pallor, icterus, cyanosis, generalized lymphadenopathy. So pallor generally you see in lower palpebral conjunctiva, icterus you can see on the sclera and also the upper bulbar conjunctiva. Then cyanosis usually in the tongue. You can also see in the tip of the nose and also in the tip of the earlobes. And peripheral cyanosis generally seen in the tip of the fingers and toes. So generalized lymphadenopathy, you have to check for lymph nodes in the neck, in the supraclavicular area, in the axilla and also in the groin. Make sure you are checking all the areas, and if examiner asks, even if you didn't check, make sure that you have examined those areas, or else examiners will be very furious. Few examiners will be very particular about lymphadenopathy. They'll ask you, did you check in groin, did you check in axilla, did you check in neck, did you check in supraclavicular areas. Make sure all those areas have been adequately checked. And pedal edema, then head to toe examination. From head to toe you have to see various signs. Okay, then vitals. So vitals, so what is the pulse rate and again pulse, you have to describe in rate, rhythm, character, volume, any radiofemoral or radio-radial delay, just like routine pulse that you check. Condition of vessel wall, is it normal or is it thickened? Whether all peripheral pulses are felt equally on both sides. Then coming to blood pressure, what is the respiratory rate and type? Is it thoraco-abdominal or abdominothoracic? So if you want to write, you can write the type, or else just write respiratory rate, and you see the JVP and you mention the SpO2. So vital should include pulse, BP, respiratory rate, JVP and SpO2. So then you should come into systemic examination starting from upper respiratory tract. So for this systemic examination, so I have given the recorded videos. So you must have seen all those recorded videos that we have uploaded. So in that there is how to inspect the lower respiratory tract, inspection, palpation, percussion and auscultation. So don't worry, this I will upload this respiratory system case taking. So till now we have discussed the basic case taking. So from the patient demographics, chief complaints, history of present illness, history of past illness, treatment history, family history, personal history. Then we have gone through the contact history, general examination, what should be seen. So vitals, what should be written, and after vitals you can go into the respiratory system examination per se. So systemic examination of respiratory system should start from upper respiratory tract. So ear, nose, you have to look for any polyps, postnasal drip, deflected nasal septum, sinus tenderness, and throat oral cavity should be examined. Then how to systematically do inspection, palpation, percussion, auscultation. So I have discussed in those recorded videos. You can just go through, and everything I have discussed according to this sequence only. And then once you have examined this respiratory system, make sure you are also examining the other systems. So if they are not abnormal, just write down the CNS, higher mental function, sensory motor function examined or normal. CVS, both heart sound heard. If there is any murmur, you mention, or else no murmur. And GIT abdomen, just soft, or if there is any organomegaly, you should write. So make sure you are not only examining the respiratory system, you are also mentioning about other systems, CNS, CVS, GIT. Then coming to the provisional diagnosis. So provisional diagnosis should contain the anatomical aspects, the pathological aspect, the etiological aspect, so any complication. So this will be the provisional diagnosis component, anatomical. Now suppose patient is having a right-sided disease. So which side? Is it right side or left side? And if you want to say if it is a parenchymal disease, suppose patient is having collapse. Is it upper lobe or lower lobe? Then pathology. Is it pleural effusion, collapse or bronchiectasis? So right upper lobe collapse. So what can be the etiology? So is it tuberculosis, or is it, if it is due to COPD, smoking, or if it is due to malignancy? So probable malignant etiology. And is this patient presenting with any complication? Suppose patient is having dilated veins over the chest or neck swelling. So superior vena cava obstruction. So I'll just give you an example. Say, for example, there is a patient with right upper lobe collapse. So this is with of probable malignant etiology with SVC obstruction. So here this anatomical component is right upper lobe. Anatomical component is right upper lobe. Whereas pathological component is collapse. Etiological component is malignancy. Whereas the complication here is SVC obstruction. So this should be the complete provisional diagnosis. So once again, I am stressing you the fact your diagnosis should have all these components. There should be anatomical component. There should be pathological component. There should be etiological component. And if there is any complication, you can just mention that complication. So with this, we will conclude the session for today. So I started from basics, students. So today we have a brief overview. So we have discussed the respiratory system diseases. So what are the common symptoms that a respiratory system disease can cause? And we have discussed in detail what is shortness of breath, what are the grades, and what are the types of breathing, what is cough, the mechanisms, the duration of cough, special types of cough, and sputum. We have discussed about hemoptysis, and most important of all, significance of general examination in respiratory disease, and what are the theories of clubbing that everybody should know. So before concluding, I will give you an easy way to remember what are the causes of clubbing. So causes of clubbing, very simple. System wise you remember. What are the respiratory system causes of clubbing? So first thing is bronchiectasis, lung abscess, interstitial lung disease. So why I am discussing it last is to make sure you will not forget the causes of clubbing. Lung abscess, bronchiectasis, ILD, malignancy. So TB can also cause, but these are common. Then coming to cardiovascular causes, congenital heart diseases, congenital, especially cyanotic heart diseases, congenital cyanotic heart diseases. And next is subacute bacterial endocarditis, subacute bacterial endocarditis. Whereas GIT causes cirrhosis of liver and inflammatory bowel diseases, IBDs. So what are the IBDs that you know? Crohn's disease, ulcerative colitis. Then last we have endocrine causes, especially thyrotoxicosis. So if you go system wise, at least you can tell 8 to 10 causes. So the causes of clubbing, you can divide it into respiratory system causes, cardiovascular system causes, GIT causes, endocrine causes. Respiratory system, 4 common diseases: bronchiectasis, lung abscess, ILD, malignancy. CVS, congenital cyanotic heart disease, subacute bacterial endocarditis. GIT, cirrhosis, inflammatory bowel disease. Endocrine is thyrotoxicosis. So clubbing, very important. They'll ask you Lovibond angle, they'll ask you Shamroth sign, they can ask you the humoral theory, they can ask you the cause of clubbing. So few examiners will be asking about the grades of clubbing. See, again, grades of clubbing is not uniform in all textbooks. Recent article in Lung India has given grades of clubbing in a different manner. So usually the grade 1 is nothing but the obliteration of angle between nail bed and nail base. So then there can be some fluctuation. Then there is this parrot beak appearance, drumstick appearance. So usually nowadays we are not using those terms anymore. So just we see whether there is clubbing, yes or no, and what can be the possible cause of clubbing. So we will see, and accordingly we are going to evaluate. So this is a brief overview of symptomatology and basic case sheet writing. So I hope it was useful to you. So now this session is open for any doubts. If you are having any doubt, you can ask me.